Welcome to Prevention 101, a 5-part series exploring the foundational principles of substance misuse prevention on college campuses. This series is brought to you by the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery through The Ohio State University. Module 5 features Dr. Dolores Cimini of the University of Albany, who will explore evidence-based practices and how to make them work for your campus. Dr. Dolores Cimini is a New York State licensed psychologist who serves as the Assistant Director for Prevention and Program Evaluation at the University at Albany Counseling and Psychological Services. She is also the director of the university's award-winning Middle Earth Peer Assistance Program, a student-staffed agency recognized as a model program in the area of alcohol and other drug misuse prevention by both the U.S. Department of Education and the Center for Substance Abuse Prevention. Dr. Cimini has served in a leadership capacity for the University at Albany's comprehensive prevention program focused on addressing alcohol and other drug misuse, mental health concerns, and risk for suicide, as well as other related behavioral health areas. She is an adjunct clinical professor in the School of Education, overseeing 8 courses in prevention, behavioral health promotion, and peer assistance and supervision. Recognizing the importance of linking science and practice in her work, Dr. Cimini has provided leadership on over $8 million in award-winning federal, state, and private grant-supported behavioral health projects at the University at Albany. The screening and brief intervention program developed by Dr. Cimini, the STEPS Comprehensive Alcohol Screening and Brief Intervention Program, has earned 10 national awards for best practices in behavioral health care and was listed in SAMHSA's National Registry of Evidence-Based Programs and Practices in January 2014 after undergoing rigorous peer review. Dr. Cimini is a member of the National Advisory Council for SAMHSA's Center for Substance Abuse Prevention and the American Psychological Association's Commission on Accreditation, and is a consulting editor for the Journal of American College Health.
Hello. Welcome to the presentation entitled Good Ideas Are Not Enough, Making Evidence-Based Practices Work for Your Campus. So where do we begin? Science has done a lot for us over the past decades in helping us understand what works to address drinking and drug use on college campuses. There is now a very strong base of evidence-based practices that we can draw from. So the good news is we don't have to reinvent the wheel. We can look to a variety of sources, journal publications, databases, and the like to help us move forward. So what are evidence-based practices? The term evidence-based practice was first developed in the mid-1990s in medicine. And what evidence-based practices are defined as are practices that have been tested through research, that have been examined with particular populations and having an understanding of such populations, and thirdly, that they have been adopted and modified to meet the needs of the particular population. So if we apply standardized practices to our work that are consistent across time, if we have a good understanding of our population that we're working with, and if we can apply those things and test what is actually working or not working on our campus, we have an evidence-based practice. What helps us determine evidence-based practices and whether they are working? There are a number of characteristics, and they have a lot to do with research. First of all, what we need to do is have a control group and a comparison group, comparing what we are trying to test with other conditions. A control group is a group that does not get the same intervention that we're trying to test. And a comparison group is a similar type of group. The difference is that a control group is one that is randomized. That is, if you have 2 students, one is randomly placed into your intervention group and the other is placed into your control group. A comparison group does not involve randomization. So what we're doing here is then we're using natural groups. We also use surveys and assessments before we do the intervention and after. So we do a pre-test or baseline assessment or a post-test assessment. And we compare pre-test and post-test. We also look at behavioral indicators of change, and we try and answer some specific questions. We look at specific things and how they are changing. So what we look at is things like drinking frequency and quantity. We look at negative consequences of drinking or drug misuse, and we also look at protective behaviors or things that might reduce the risk for college students. There are some possible barriers to implementation of evidence-based practices. Barriers can exist in dissemination, that is, when we get information out about our evidence-based practices to other campuses, other schools, other departments. We also may have barriers in terms of adoption. We may have trouble getting resources to adopt our strategies. Implementation, that is, implementing evidence-based practices the same way they were implemented in a laboratory or in an original setting they were tested in. And lastly, maintenance. That is, we may do well with implementing an evidence-based practice, and then over time we may have some difficulties continuing to implement it in the same way, and that may affect the outcomes of our evidence-based practice. So let's talk about barriers a bit. What we want to make sure to do to avoid experiencing barriers is we want to engage in proper training of the staff who are doing the intervention. We want to train them all together if possible. We want to train them in the same way, and we want to train them using clear protocols. We have a tendency sometimes to change interventions as we go along. Or to reinvent the wheel, or to become perhaps more dramatic in the interventions we do, because if we're more dramatic, then we might find some better results. But it's very important to stick to intervention protocols. So that is called preventionist drift. People drift from the initial period of time where they learn an intervention and practice it initially. So we need to engage in ongoing training and ongoing supervision of interventions in order to have them remain consistent and true to the tested laboratory setting. Keep in mind that we can learn as much from interventions that don't work as we can from those that do. The key is to follow the methodology that we propose, that is, to make sure that we're doing the intervention the way it's defined as being done, and that we test what we're doing through survey and other assessment measures. So let's look at some survey characteristics that we might want to consider when we're building evidence-based practices. There are several considerations that we might want to think about when administering surveys. First of all, we want to select surveys that most accurately assess the variable that we're interested in. If we're interested in examining the frequency and quantity of alcohol use, for example, what we want to do is select a measure such as a daily drinking questionnaire and the like that actually looks at the frequency and quantity that we want to measure. Secondly, we want to be sure that we're not inadvertently assessing high-risk periods of drinking post events such as Halloween, New Year's, Thanksgiving, spring break. So if we ask a question about drinking in the last 30 days and we're asking it 5 days after spring break on our campus, we're going to get higher rates of drinking because of the existence of spring break. And that may actually mask the results of our intervention. So we want to be sure that the timing is appropriate. Next, we want to consider a range of variables that we want to measure, not just one thing, but many things. And also, we want to look at the mode of administration. Perhaps on your campus, it might be easier to do a web-based survey, and you might get a high response there. Many campuses do have challenges with web-based surveys, and in that case, however, you may want to consider using paper and pencil surveys or focus groups or other ways of measuring change. So those are just some survey administration considerations. So data collection considerations. It's important when collecting data to keep periods of data collection constant. So if we are collecting data in February of one year, we don't want to collect follow-up data in October of the following year. And that relates to the topic that I discussed in the last slide, that there are some peaks and valleys in the rates of drinking and drug use across different campuses. So selecting an interval that works for your campus in advance will really help be able to assess in the most accurate way. Here's a little cartoon. It really reminds me of data sometimes feeling intimidating to some folks, but in fact, data can be our best friend. So when we conduct data analysis, there are a number of things we can do to help make our findings more accurate. So what we want to do is first look for outliers. So we have typically a data set that we work with, and outliers are those that really are above and beyond what we would expect from a college student. So if we ask a college student on a survey question, how many drinks did you consume in the last week? If a respondent says 100 drinks, that's really infeasible. So that's an outlier. And what statisticians do is that they then remove that case from the data set so that the data set is not distorted. Second, think critically about your findings. Think about different scenarios that might be occurring. Think of the context. Think of your data and consider your data with a healthy skepticism. Analyze your data in a way that takes in the campus environment that you work in and that is sensitive to changes in your campus environment. And lastly, beware of making categorical statements. Okay, let's take an example of the drawbacks of making categorical statements. So consider what you see on this slide here, that 85% of students drink 0, 1, 2, or 3 drinks, and then 15% are higher than that. So if we find that some students are drinking higher than the 85%, for example, somebody who drinks 20 drinks a week who would be in that top 15%, and they reduce their drinking from 20 drinks a week to 15 drinks a week, they're still considered to be in that top 15%. They're still considered to be high risk. However, they have made a significant reduction in their drinking that it's noteworthy, and they have enhanced their health. So what we need to do is not categorize necessarily and solely via high risk and low risk, but look within the categories and see if there are reductions within the high risk group and within the low risk group. And so that will help us refine our data analysis and help us understand that in fact, even though at follow-up there are some students that are still engaging in high risk behaviors, over time they did reduce, and that's progress. Before declaring success or failure, remember that anything that we do, any one thing that we do, is part of a bigger puzzle, and that it is part of a more comprehensive set of interventions and programs that we do at our institutions of higher education. We need to examine moderators. What moderators are things within our students like gender, sex, age, fraternity and sorority membership, class year, that make interventions potentially work less well or better than other interventions. Those are called moderators. We also need to look at what we call mediators, and that is things in the environment that may help an intervention work better or may be associated with an intervention working less well. So for example, if we were doing an evidence-based intervention and we experienced during the time of the intervention an alcohol-related death, that may influence the results that we see. So we always have to look at things in context and continue to collect our data. And then finally, what we want to pay attention to is to, at all times, implement our interventions with fidelity. That is, implement them in the way that they were originally designed to be implemented when they were tested in a laboratory or in the original study. So when evidence-based practices don't work, where do we look? How do we understand that? Well, there are several things that we might want to look at when we are examining why things are working or why things are not. And they are collaboration, networking and program promotion, building intervention capacity, evaluation of our interventions, establishing diversified funding and resource bases, and engaging from the very beginning in sustainability of interventions. And we're going to talk a few minutes about each of these. When implementing evidence-based practices, collaboration is key. We need to have partners to deliver very strong evidence-based practices. It takes a village to implement an evidence-based practice. It's not really a cliche. It's actually a fact. No one person can deliver an evidence-based practice to the scale that a college campus needs it. So we want to get partners that are interested in the same things we are, that are willing to put in time and resources and personal strengths into the delivery of the intervention. And resources don't necessarily mean money. It may mean somebody with a particular strength in interacting with students or getting students to an intervention that's needed and the like. In addition, we need to strategically position collaborators so that they are exhibiting their strengths when engaging in the intervention. The other question that we want to ask is, have we engaged our partners in diversified roles? Again, it plays to people's strengths. Have we really maximized our collaborators and engaged them fully so that they feel that they are contributing and that they feel that they are really, really a part of the intervention? That's very critical. Networking and program promotion is also very important. Everyone who is involved in any aspect of an evidence-based practice is engaged in that practice, whether developing it, implementing it, evaluating it, recommending students to participate in the intervention, and the like. And it's important to keep these stakeholders engaged and excited about what we do through networking, that is letting people know how the intervention is going, keeping them updated with periodic data reports, keeping them engaged in updates around the evidence-based intervention. It goes without saying, but a thank you can go a very long way with our partners. When we promote our programs, when we share our successes with our partners, with our campus, with our media offices, which is something I would highly recommend, it is critical to acknowledge all of the partners that have made the evidence-based practice and its implementation and evaluation a reality. Building intervention capacity. This is something that's very, very central to evidence-based practices from the start. Many evidence-based practices either succeed or fail based on the fact that they do or do not have sufficient resources to be implemented. So what I would recommend is that you look at these questions on these slides and see what is necessary, determine what is necessary to build capacity to develop, deliver, and evaluate your evidence-based practice, your evidence-based intervention. Is it dollars? Is it staffing? Is it the knowledge of a researcher? Is it getting students involved in recommending other students to participate in the intervention? All of these things really help strengthen capacity for evidence-based interventions. Evaluation of interventions are really the linchpin and the central component of evidence-based practices, because evidence-based practices are built on the fact, and they exist on the fact that the interventions that we are testing or that we're doing work. So we need to be sure that we have the capacity to evaluate our interventions. We need to make sure that we have someone on our team who can work with statistics, who understands methodology, who can let us know through data reports whether our intervention is working before we get too far into it and utilize too many resources for something that may not work. So we need to look at where our partners are there. And one of the things that's really worked well for many campuses is to develop partnerships with faculty members and academic departments on our campus. Many faculty members are very interested in alcohol and other drug misuse research and actually getting access to student populations that we work with on a daily basis. It's really a win-win situation. So as we are getting the expertise of researchers in data analysis and evaluation, the faculty members also benefit by getting the opportunity to be able to collect data, to access our population, and to publish, which is something that they're required to do very often to keep their positions as faculty members. So those are just some suggestions, and if you look at some of the questions on this slide, it will also help you navigate in the area of evaluation capacity for your evidence-based interventions. Establishing a diversified funding base. Now this says funding base, and I understand that the first thing that we all think of when we build evidence-based practice is how are we going to fund them? How are we going to pay the staff that does the evidence-based intervention? How are we going to provide incentives for students to participate in our evidence-based intervention if that's something that we want to proceed with? How are we going to continue the intervention over time? So certainly funding plays into this, but also there are partnerships that we can establish with different departments to obtain non-funding resources to help our interventions keep going. For example, we may have partners at our University Health Center who can assist us in recruiting students for our evidence-based interventions. We can train some staff members in residential life to help us implement evidence-based interventions, even though we may be based in a counseling center or health promotion office. So again, the statement, "it takes a village," really comes to life when we think about diversified funding base and diversified resources to continue our interventions. One caveat that I want to make before we move from the slide is that many people in colleges and universities have received grants to implement evidence-based practices over the years. At this point in time, it's become more and more challenging to obtain outside grants to implement evidence-based interventions. So I would recommend at this point that we not rely solely on seeking grant funding to implement an evidence-based intervention. And if we're fortunate enough to receive a grant to implement a new intervention, that is the time at the very beginning that of the project that we start to consider how are we going to sustain it when the grant is gone. Sustainability. This is very, very, very important. And as you see from reading the statement on this slide, the most important thing when we consider sustainability of an evidence-based intervention that comes into play is the skills of the leader. Okay, many of you who are listening to this webinar right now are leaders on your campuses and in your profession in the delivery of practices, best practices to reduce alcohol misuse and drug misuse on your college campus. And so it is incumbent upon all of us as leaders to consider the bigger picture and how we develop, implement, and most importantly, sustain our programs that are evidence-based. Here you see a diagram with the word sustainability in the middle. And in each circle around the word sustainability is a strategy that we might consider involving ourselves in to sustain our programs. And many of them are very intuitive, so I'm not going to go over them. You can look at these yourself. Developing a work group and having that meet regularly is very important to troubleshoot and make sure evidence-based interventions are going well. Also, linking with your campus alcohol and drug task force is very important because then they can bring the good word about the work that you do to your college administrators and particularly your college president. Engaging in annual reporting that is consistent and aligns with the mission of your university and the division that you work in, which is more often than not student affairs. Partnering with colleagues at other campuses, working with them, consulting with them, going to conferences, presenting at conferences when you have results, and not just results that show that your intervention works, but even results to show that it doesn't work are very important to share. Getting the good word out about your evidence-based intervention, letting your campus know, letting your media office know, letting the higher ed center know. I'm sure they would be very happy to learn about work that campuses are doing across the country. So these are certainly just some examples of how we can sustain our evidence-based programs and practices on our campuses. Before I end, I'd like to direct you to a couple of resources that will help you locate and identify evidence-based practices that might work for your campuses. First, the National Institute on Alcohol Abuse and Alcoholism has developed a college AIM alcohol intervention matrix listing evidence-based practices addressing alcohol misuse. And these are individual interventions, interventions for the entire student body, and policy interventions. You can go to the website that's listed before you and actually enter your campus characteristics, and the College AIM database will produce potential interventions you might want to consider that match the characteristics that you entered into the database. So it's really a very helpful resource. The other resource that I would recommend is SAMHSA's National Registry of Evidence-Based Programs and Practices. This is a registry of evidence-based practices for all kinds of populations. Now, not just college populations, but also other populations that have been peer-reviewed and placed in the registry because they have been found to be tested rigorously and they've been found to be successful with the specific population of focus. So again, you can enter a specific set of keywords and can locate interventions that are most appropriate for your campus. That said, it's important to recognize that one size does not fit all, and that even though interventions may be listed on a registry and may have been found to be effective on other campuses, even those with similar demographics as yours, it's important to do ongoing evaluation through baseline and follow-up assessment to ensure that the intervention, when applied to your campus, is working just as well. To coin a phrase, I would say keep calm and carry on with your evidence-based practices. Thank you.